Sometimes the trials don't go the way we expect, and yet a negative trial finding can be very important. The PALLAS trial had some surprisingly negative results. Can you tell us a little bit about PALLAS?
Sure, PALLAS came on the heels after Athena, and this was studying dronedarone, a new antiarrhythmic that is similar to amiodarone with less toxicity, and looking to see whether dronedarone improved outcomes in patients who have permanent atrial fibrillation. In Athena, the study tested the hypothesis in patients with paroxysmal atrial fibrillation, and they found lower risk in those who were on dronedarone compared to placebo. So naturally, it begs the extension in those patients who have permanent atrial fibrillation, potentially could dronedarone also benefit in terms of stroke, cardiovascular death, and heart attacks.
And what were the main findings from the PALLAS trial? What should the clinicians take away from that study?
Well, it's quite surprising. It was stopped early because of an increased risk of harm. And so, in fact, there was a doubling of the risk of cardiovascular outcomes in those patients assigned to the dronedarone arm. Not just the main cardiovascular outcomes, but increased mortality, increased cardiovascular death, increased stroke, increased heart attack, 2 times in almost all those outcomes. It turns out that when you really think about those patients who have permanent atrial fibrillation, a high proportion of them also have comorbidities such as heart failure, as well as other medications that they take and other antiarrhythmics like digoxin that could put them at higher risk of having a negative outcome when also put on an antiarrhythmic. In the earlier studies in the Andromeda study that looked at this medication in patients who have heart failure, it also was a negative trial with increased risk of mortality. And so put in that proper context, one has to now reconsider the use of dronedarone and its efficacy. I think, again, you have to reconsider that in all patients with atrial fibrillation.
Do you think that patients with atrial fibrillation now ought to be managed with rate control, or should we still strive for rhythm control, or is that debate still open?
I think that debate is closing quickly. I mean, in those patients who remain overtly symptomatic despite the aggressive medical care for rate control, there is maybe a small role still for the consideration of rhythm control. Even the heart rate control is being much more liberalized based on previous results now. But I would focus in my patients on rate control and proper and thorough anticoagulation.